welcome everybody. This is the Homeless and Housing Services Providers Medi-Cal Academy. We are here at session 4, Money Matters. So my guess is this is one of the big sessions for people. They want to do this service. They've been delivering their services for a long time, but gosh, how do we make the money work? Well, that's what we're going to talk about today. So we're excited for the conversation, and let's shift to the next slide. So just a little bit about CSH. CSH is a national nonprofit, 29 offices, we're in 13 states, and we work to advance solutions that use housing as a platform for thriving communities. We look to serve individuals who've been historically and systemically excluded from systems, excluded from care, and try to address those inequities over the long term. So we're really happy. We know that's a mission of you all as well. Next slide, please. We're going to do your training team today. Myself, Marcella McGuire, I lead CSH's health and housing work nationwide. I'm a psychologist by training, and I am based out of Philadelphia. And I'm going to hand it over to Allie.
Hello, everyone. I'm Allie Nemi. I'm with North Star Policy Consulting, working in partnership with CSH right now. I am based in Minnesota and was helping or have been helping in Minnesota with providers getting enrolled and starting services and a new housing related Medicaid benefit there. Prior to being a consultant and helping the agencies, I was at the state and worked on designing the benefit. So that's kind of my background and experience, and I'm excited to be with you all in California and working on it now too. Thanks.
All right, and Cheryl?
Hi, everyone. If you've been in previous sessions, you've heard my spiel, but if you haven't, my name is Cheryl Winter. I'm a licensed clinical social worker. My background's in permanent supportive housing and assertive community treatment, and I'm based in Los Angeles. I'm so happy you're all here.
All right, she's not on the slide deck, but she's helping us out today. Ambrosia, can you introduce yourself too?
Sure, good afternoon. So I am not in Los Angeles, but I do share the same time zone. I'm in Las Vegas, Nevada. I too am a licensed clinical social worker. A lot of my background is in direct service space, in the behavioral health care side, in healthcare, and in homeless services, as well as doing some oversight for some programs for my local COC. So I've kind of been a little bit between two different worlds and hoping to bring all of that knowledge and experience along with the work we've been doing at CSH in different states, doing similar academies for providers who are learning to bill their benefit or services. So you might have seen me already. I won't be talking as much today, but I'll certainly be available as a support here during your session.
All right, thanks, Ambrosia. And for folks who are just coming in, we're asking everybody to put their name and their agency and their county in the chat so we can get to know who's in the room. Also, if you want to put in sort of what your role is in here, because we're going to talk about finances, we imagine that we're going to have all different kinds of roles in here. So we might have people who've got a chief financial officer role or a financial analyst, a billing specialist role. We might have program people. We might have executive people, all different kinds of places. But tell us about you so we know who's in the room. And while we can't be in person, we can at least work engage with you. And with that, I'm going to hand it over to Cheryl. She's going to give us our overview on where are we in the Medi-Cal Academy.
Hey, we are at session 4, so almost halfway through. We are today covering Money Matters, the basics. So this is an introduction to how you understand your total cost of care, how you estimate cash flow, how you project added costs, ongoing and startup, if you're going to pursue a Medi-Cal community support that's housing related, and then how do you project revenue? What are the things that are external factors that could impact how much you receive in revenue, and what are internal factors that impact that? On March 8th, so we'll have a few weeks of break, and then March 8th, we're going to come back together for Money Matters 201. And this session, we are going to be reviewing several different tools that we want your agencies to be able to use, where you can understand what your per member per month rate is with the services budget tool, where you'll be able to project out revenue over a period of months so that you can start to see what that cash flow might look like. And then we also have some experts joining us in that 201 session to talk specifically about the guidance to help you avoid double dipping and to comply with requirements that say that these funds can supplement but not supplant. So we'll break that down in the 201 session as well. And then April, we have 3 sessions. So incorporating community health workers and peers into your workforce. Those are 2 other Medi-Cal benefits that are separate from community supports, but may be of interest to your agency if you currently help with healthcare navigation and care coordination and employ people with lived experience. And then the next 2 sessions in April and that first session in May are really going to be important for your quality improvement and compliance staff and your program managers that oversee frontline staff, because it's all going to be about your policies and procedures. So what processes need to change, what workflow might need to change, how your documentation may be the same or need to look different. So your assessments, your individual service plans, and then your day-to-day documentation of services. And then also, what are the compliance requirements related to submitting claims? So for your billing specialists. Lastly, we'll round it out on May 17th with the electronic health record elements to support your documentation. So this is what data systems are you currently using and what fields or records or reports will you be interested in having access to or creating or building out in your current data systems? Or do you need to start thinking about getting access to another data system to serve as your electronic health record? And thank you for all of you that are putting your intros in the chat, and I will hand it back to Martella. Or no, to Allie, sorry.
Great, thanks, Cheryl. All right, so we can dive into the content now. We are happy to take questions in the chat as we go along, and I'll pause here and there as well for if somebody wants to unmute and ask questions. If we get too far off topic, we might have to table things or circle back, but this can get kind of complicated, so we'll try to make sure that everybody can keep up as much as possible as we go along. All right, so here's just a little preview of what we're going to be talking about today, laying some groundwork in terms of concepts, terminology, and then talking about on your end how you can project your costs, how you can project the revenues, demonstrating that to the managed care plans and the state. And then Cheryl's going to wrap up and kind of tie it all together with some resources for you all and talk about contracting and that sort of thing. I also will mention that, as Cheryl said, this is the 101, and then we're going to have a 201 where we have a little more tools and it might be a little more interactive. So today might be, unfortunately, a little more talking at you than we've done in the past, but know that we will have more kind of like interactive pieces at the 201 coming up, and this is to lay the groundwork for all of that. All right, so we want you to, again, be able to understand the terms and concepts that we'll be talking about when thinking Medi-Cal and contracting, thinking about what should be in your cost and revenue projections, recognizing how different variables can impact those and how that impacts your overall planning, so that you have a good idea about your financial projections when you're contracting with the MCP, if you haven't done that yet, and also have some resources at the end. So we, excuse me, want to start out by giving a baseline around thinking about the difference between grant funding and Medi-Cal reimbursement funding. And this can be a big shift for a lot of homeless and housing service providers that are used to primarily relying on grant funding, either from the state, HUD, private grants. I think those are maybe more traditionally in terms of supportive services funding, what agencies use to finance their supportive services. And it's a little bit of it's really a mind shift to go from that type of funding to a reimbursement phase. So if you haven't done it before, some of you may have other Medi-Cal services that you provide, and so you're kind of familiar with it. But if you haven't done it before, take some time to kind of think about the differences and wrap your head around them. So when we talk about grants, typically we're talking about funding for programs. And when we say that, we mean that the funding source is going to be looking at everything that's included or required to provide a service or to provide rental assistance, for instance, whatever you're doing for the people that you're helping, and bundling that all together and trying to kind of make you whole for what you're going to spend on that. Whereas when you're thinking about a Medi-Cal reimbursement process, you're really, instead of looking at the entire program, you're thinking about how much you're getting paid for per person and for the services delivered to that particular person. So that is kind of the main shift. And for me, because I started working in housing and homeless policy and have, over the years tried to like educate myself more in the healthcare world and have dug into that. And really when it kind of clicked for me was when somebody said, we are paying for a service provided. We're not paying for a program. We're not paying for staff. We're paying for a service provided. And that really is like a different way for a lot of times for programs to think about it. So sometimes I'll have agencies will ask, once we get paid, are we allowed to spend the money on, buying a van or something like that? And that is a question you would ask in the grant area, but irrelevant in the Medi-Cal area, because once you get paid, they're not looking at what you're doing with the money afterwards. What health care reimbursement is caring about is that you provided the service that you said you have provided up to the standards that are required for that particular person. And you have documentation that you provided that service when you did it and that you did it correctly. And then the money comes on the back end, and what you decide to do with that money and how you spend it is up to you. Obviously, you're not going to be able to like provide quality services and up to the standards required if you don't spend that money on, paying your staff and whatever, rent and licenses and all those types of things. But that is not, nobody's going to be going back and looking at that as compared to like a grant program. And a lot of the ones that I've worked with, you have to submit a particular budget where you're looking at categories of spending, staff, supervision, rent, materials, insurance, all those types of things. And if you want to change how you're spending that money, many grant programs require you to go back to them and say, you know what, we are, our projections of our costs are different than we anticipated. We need to change our budget. I know, like, that's what they do with HUD, right? So that is a totally different way of approaching how you're getting paid. That can be a really, again, like a huge mind shift for programs. So I think we can go on to the next slide. So administratively, what that looks like is that in the grant world, often you're writing a grant proposal, and then you have a contract that says like how much you're going to get paid and what you're going to spend that money on. You get that award often on the front end. That's not always how it works. Sometimes they do like, quarterly payments or different things, but usually you're getting some amount of money on the front end. You do the work and you write a report to the funder. We served this many people, and here are outcomes to verify that you spent the money on what you said you were going to spend and you did what you were going to do. In the healthcare world, it's kind of the reverse. So you have a provider enrollment process that you might be going through, an agreement or a contract with the managed care provider that says, we are qualified to do this work and we agree to follow all the rules. And this is how much, once we do this work, this is how much you will pay us. Then you do the work, serve people, all that type of thing, document it, submit the claims, and then get paid. So that requires you to have some sort of ability to pay for or have a way to provide that work without getting paid until farther down the road than you would with a grant. Great. Again, feel free to jump in with questions. So both models, we talked about kind of the differences, and then now we want to talk a little, point out some of the similarities. So again, the grants, you're kind of looking at program level funding. You're getting funding at or before or during the program launch. And then for the Medi-Cal reimbursement, you're getting a reimbursement by a person served. And then the funding is you're getting paid after the fact, after the services have been provided. But both of these models require that you know your true or total cost of care so that you can accurately predict what or as close as you can, predict what you're going to be spending to provide these services, and make sure that the funding that you're getting will cover what you want to provide and what you want to do, so that you can have your cash flow projected and expenses and revenue anticipated by month. In the grant program, often what happens is you do all that on the front end, present that to the funder, and they will agree to make sure that, either all your costs, depending on how the grant is set up, or a certain amount of your costs are covered by the grant. With the Medi-Cal reimbursement, it's really up to you to be looking at what are these total costs that you have, and is that cash flow going to match in terms of how you're projecting your revenue, going to match with what you're spending, so that you can make it work financially. And then obviously with both programs require you to follow certain compliance and financial management, and not allow supplanting. As Cheryl mentioned, we're going to talk more about that kind of supplanting concept at 201, so I won't go into that too much right now. Oh, thanks. I was going to ask you, Cheryl put in the chat about when the plans have to pay within 30 days and 99% within 90 days. So that's kind of the expectation that you can work with. Again, it's only if the claims that you submit are clean. So if there are any mistakes, they can be pushed back to you and you have to fix them, and then it pushes that payment time farther down the road. Okay, so now that we kind of set that groundwork of grants versus Medi-Cal reimbursement, we want to talk a little bit about the different ways, the different payment mechanisms that Medi-Cal can reimburse for services provided by person. So most of what you will be doing is through a bundled payment. So in this instance, there is a single distinct payment per member or case, and that it is payable within a month the person is enrolled. So sometimes you'll hear people say PMPM, per member per month. And so everything that you do within that month that falls under that service category is expected to be provided within that payment amount that you receive for that month. And if you do more for somebody that month, you don't get paid more. You do, on the other hand, if you don't do as much that month, you get paid more than you would if you're billing fee for service, which is where you're getting a payment for a discrete good or defined length of time. So that might be per hour, per 15-minute unit, per diem. And that is when you're tracking your time, adding all that up, and then submitting a claim based on actual time spent. So we don't think that there are currently any managed care plans that are doing fee for service for the housing related community supports, at least not in our the technical assistance kind of areas that we're working within. But if somebody is, that we'd be interested to know that. So almost all of you, everybody is getting a bundled payment per month for the services portion. Then when we talk about something like housing deposits where they're paying for first and last month's rents or the security deposit application fees, that type of thing, that mechanism is a cost reimbursement up to a cap. So there's a cap on the total amount of services goods that you will be reimbursed for. And again, it's for actual costs. So even though they can pay up to $3,000, we've heard up to $6,000 for some of these claims, you're submitting what you actually paid for that service or good. All right, so we have a couple questions in the chat, so I'm just gonna pause for a second.
Oh, we've got them. We're getting them out.
Okay, great. All right. So I think I am turning it over now to Marcella to talk about calculating or knowing and articulating your total cost of care.
Total cost of care. What does it take to do your work? You're trying to build a financially sustainable program. And so what you need to do, what you need to understand is what we're calling your total cost of care. When we think about budgets, we often think primarily about direct services personnel. And that's right, that's usually your single biggest budget item, but it's often not your only budget items. We really want you to think through all of the different places and all the different pieces that you need, because if you're going to build a sustainable program over time, you really need to get your total cost of care. You need to understand that total cost of care, and you need to make sure you're being reimbursed in a way that covers that total cost of care. So knowing it, understanding it, being able to articulate it. When we say articulate it, I mean a spreadsheet that says, these are our staff, this is what we pay our staff, these are our QI people, these are our billing specialists, these are our administrative support. We're going to go through all those other things that should go into a program budget that you want to be able to say. If you go to Medi-Cal and say, I'm not getting paid enough, if you go to your MCP and say, I'm not getting paid enough, you're not going to get very far in that conversation. If you go to MCP and say, here's what it costs to do the program, I'm not promising you, but there's more hope. You have to be able to articulate what it is you're spending on in order to have that conversation about rates. Rates are how much they are paying you by how much you have decided to do. So when Allie's talking about per member per month, you're getting paid a certain rate for that month. Next slide, please. So contracting we want you to be able to be contracting for a rate, and we want you to be advocating for a rate that covers the total cost of care for your delivering services. And we're going to get into the tools that help you understand this, the services budget tool, the startup tool, the cash flow tool we're building in the next session. But we want you to get the concepts down now so that when you get to those actual tools, you'll understand and be able to use them. So if your agency's never done Medicaid before, there are startup costs. There are startup costs to look at your billing system. There are startup costs for consultants to redo your policies and procedures. All kinds of ideas here about what, because you're new to Medicaid, you're going to need this new work. It's highly likely you're going to need a new documentation system, possibly, or a new billing system. It's not certain, and that's an agency choice, but depending upon what your MCP is requiring to submit for payment, that's going to impact what some of these new Medicaid related costs. As I said, next session, we're going to go through the services budget tool in more detail. That will help you build up through that total cost of care. We want each agency, as they're building their startup plans here, you're building your work plans, we want you to set reasonable goals. We want you to understand all the pieces of the process. We want somebody at the CFO, the executive level, the program level to understand what are all the steps you're going to have to go through from, hey, we should do Medi-Cal, to we have a financially sustainable program. And we want you to understand how long that process is going to take. So we want you to help you to develop a work plan that gets you to high quality supportive housing services and what changes may need to happen into your current operations. The requirements about who can deliver the service, who can supervise for the service? Is there new training that's required? If you have a HIPAA, if you are working on becoming a HIPAA compliant agency, there's an annual training on HIPAA that's required for all your staff that touch clients or residents and direct services in any way. And we want all of your team to understand all of the pieces. We want your program people to understand what your billing specialist does, what your quality person does, so that they all know what piece they play in building a high quality, fiscally sustainable, supportive housing program. So next slide, please. So we're going to talk more about determining your total cost of care. Next slide. And we're going to talk about some of the things. As I said, the most commonly we think about is direct services, but let's talk about some other things. Think about estimating costs with what we call the 4 lenses here. Programmatic, what are your programmatic related costs? What's your direct services staff cost? What's the supervision cost, training cost, making sure everyone's got the training and compliant. You may have a learning management system that tracks all of the different trainings people go in, et cetera, so that you can do the service, the actual service provision. You want to think about this strategically. You want to think about business partnerships. Some agencies are choosing not to do a data system, but they're choosing to have, not to have a billing system, but they're choosing to partner with someone who does the billings for them. That's what's called an administrative services organization. That's an example of a business partnership that may be part of your choice here. We want you to think about how you're growing your program, how you're growing your agency over time. We want you to know what funding is available now, what funding is projected shortly afterwards, and what conversations are about long term. We want to make sure that you've got a financial management system in place that can, what we call braid funding streams, meaning you got this pile of money from Medi-Cal, you got this pile of money from your COC for housing, you got this pile of money from a housing department, et cetera. You need to be able to braid those streams. Braiding means, if you think about a braid has 3 pieces. Standard braid may have 3 pieces of hair in it, but you could pull those pieces apart and you'd still have the same hair. Financial management systems help you understand that this money came from this source, was allowed to be used for this, and we allowed it for that. Strategic is also thinking about board governance and how you work with all of these other entities, as well as how you work internally. You've got to think about it from an analytical lens. You've got to think about what data systems you're collecting. How are you documenting? How are you doing quality improvement? How does the quality improvement people have access to the records so they make sure that the documentation is correct? Managed care plans commonly do audits where they come back and say, okay, you billed for this person at this service at this day, show us the documentation to support that. We don't know how commonly that's going to be happening in the community supports program, but it does happen, and we want you to be prepared for that. Any problems, you always want to find out you want to figure out any problems within your staff and your documentation long before the managed care program does. You need to think about operations, you need to think about legal guidance, and how you gather all of this information. Finally, there's basic logistics that happen, particularly when you're shifting to a Medicaid program. The financial management systems I talked about, the billing systems and the data systems, what legal agreements are required to be in place. Is the MCP requiring you to be HIPAA compliant? If it is, how do you have to look at your legal agreements in there, who you're working with, HR and information technology. All of these add to your costs in order to be compliant with the Medicaid program. So you've got to be able to estimate those costs. And in the services budget tool, we've got a standard startup cost. You're hiring staff, you're getting new offices, you're getting new computers. What does that all cost? And then costs that are specific because you're new to a Medicaid program. So you think about each of these 4 lenses and spend time with your teams that touch each of them and say, okay, as we make this shift, what new, what different, what additional do we need in each of these different lenses? And maybe it's a separate meeting for each one of the lenses so that you can roll out. These are all the different pieces that we see from a programmatic lens, these from a strategic lens, these from logistical, these from analytical. So next slide, please. And again, I'm not looking at the chat either. So Ali, Cheryl, and Brett should jump in if there are questions or something.
So far, so good.
Okay, cool. So if you aren't sure where to begin in estimating your true cost of care, start with what it is that you're doing. Start with your existing caseload sizes. We have this many direct services staff. They're serving this many residents. They have this many supervisors. This is what the billing system costs. This is what the rent costs, current operating expenses, and current salaries. add in all of the ongoing costs that are going to be common to Medi-Cal that maybe if you were in that, when you were in that grant world, you didn't need to do, now you're going to need in the Medi-Cal, and our services budget tool breaks that out for you. You're going to need to make adjustments to current costs. You're going to be adding IT staff or adding that maybe it's not a full-time job, but you're adding new roles to current IT staff, to current fiscal staff, et cetera. Do they, how busy are they now? Is it a half-time person? Is it a collaboration with someone else? So think all of that through as you look at how many people you're projecting to serve and what time period. You want to make sure that you're building towards excellent outcomes. And as we said, quality supportive housing, and you're building towards retaining your staff as much as possible. We all are feeling the workforce challenges right now. So you really want to make sure that you're offering competitive salaries, especially as you're building this rate so that you're going to be able to hold on to staff for the long term. So next slide, please. So step one, and this is what you're going to need to be able to really take advantage of our Money Matters 201 session. Fiscal staff are going to need to be a part of that. You want access to staff salaries for direct services staff, for middle managers, for your supervisors, for your quality improvement staff. You want the personnel expenses. You want personnel that salary as well as benefits. What benefits package and what's your benefit percentage here? You want access to your current program budgets. They include your operating costs and what we call other than personnel costs, office rent, utilities, technology costs, all of those sorts of things. These are all part of what goes into estimating your total cost of care. The most sophisticated agencies we work with are able to say, for one person for a year, it costs us X number in order to serve that person. So that's what you're being able to build towards, because that at the end of the day, for a month, for a day, is what you're going for in your rate negotiations. Yeah, bring your current costs. Yes, exactly. Thanks, Cheryl. So next slide, please. So step two, you've got your current salaries, you've got your current program budgets, you've got your benefits packages, you know what that costs, you've got your other than program costs. What's it going to take for you to become an MCP contracted provider? What are your one-time costs? What are your startup costs? You may have training for everybody in the agency. In our cost cash flow tool, we talk about agencies often hire a point person, maybe somebody in the agency, somebody outside the agency, in order to do this startup. And maybe that person evolves into your program director. Maybe they evolve into your QI director. But at the end of the day, you're paying for this person before the program is paying. And so you want to estimate all of this in your startup costs. And then you estimate what are the additional administrative costs you have to pay for the billing system in order to use that. What's the support for that? And what does that cost for you? When I say support for that, I mean like, the people you call, I'm blanking on the name, people you call on the phone to say, hey, this system's not working. I don't know how to understand it. Somebody put that in there with the chat because I forget what that's called. Support, consumer support. Anyway, so these are all things. You've got some startup costs that help you, that are one-time costs. Then you've got ongoing administrative costs that are going to be built in to manage the program. You need to build that into your long-term conversation about rates. So you've got your current costs, what's your new costs, and you're putting them together into step 3. Next slide. All right. So here's just a couple of other buckets we want you to think about as you do that analysis by the 4 lenses. Direct services staff, middle managers, executive staff, whoever's in the staff picture, you need to think about them. Training, you're going to need to do training on startup for people. You're going to need to train on the program model. You're going to need to train on quality supportive services. You're going to need to train on your billing systems. You're going to need to train on how you do documentation. You're going to need training on QI. If I've operated in a grant environment, I just kind of wrote notes here and there and that was fine. And now you have to be really rigid about documentation because Medicaid requires that. That's a shift. You're going to have to do training around that. So that's going to be part of your startup cost. It's also going to be part of your ongoing costs. Think about these in separate buckets: your startup costs, your ongoing cost, your business support staff or your administrative staff, your billing staff, your fiscal staff, your IT staff, all of the staff that make the program. The program wouldn't happen without, but not who you think of as your direct services staff. And think about that in terms of staff, and then think about it also in terms of tools: your electronic health record if you use one, your billing and documentation system, and then who keeps those systems up and running for you. Supervision, make sure direct services staff is not just staff, but supervision, who's overseeing this. It's a shift in supervision we'll talk about. Most agencies at maybe not very small agencies, but medium to large agencies have a quality improvement person or a quality improvement staff. These are people who both look at the records and look at the activities and say, are we doing what we meant to set out to do? Are we fulfilling our mission? Are we delivering a quality service? And then they also have a compliance role. We said we would do A, B, and C. We have to document in these ways. We have to use the billing systems these ways. We have to have this information that fits in the billing system. Is that all there? So that if and when an audit comes around, we have all those documented records that people can see. You have to think about this also ongoing costs from IT and data plans, what phones, what tablets are you giving people, what the data systems that they are using. Most systems use there's not, hopefully very seldom we use paper anymore. You're putting this all into a tablet, et cetera, that connects to your data system. That's the ideal we have right now, but that costs on your data plan. These are all estimates and costs that you want to put in this. Next slide, please. Yep, highlight what Cheryl said. If your supervisors don't currently review assessment, service plan, documentation, you're going to have to train them on that. You're going to have to help them understand what they're doing at this new part of the role. You're going to have to help your line services staff understand this. You're going to have to communicate with your residents. This is a change. We may have them signing things that they didn't have to sign before. And that's a communications plan that you want to build into here as well. So other startup costs to consider, person-centered design. We want you, as you build out your new workflows, as you build out your new processes, this has to be grounded in the experience of your residents. They have to understand why this is happening, why this is changing. They have to be able to communicate, well, gosh, this is what I rely on for my stability, for my assistance. You have to hear their voices in this process. That takes time, that takes resources to do. Build that into your startup costs. TA or consultants, people who come in and help you make this plan change specifically for your agency. The ideal person, and there's just not that many of them, is somebody who's both worked in a supportive housing program, worked on the housing and homeless side, and somebody who's worked in the Medicaid side, so that they understand the tensions between the two systems. You may be getting new data systems or software. What are the costs related to that? You might have to put hiring bonuses in order to be able to recruit new staff. So that needs to be in your startup cost and your startup budget. You're going to have legal support in order to look at some of the contracting. Managed care contracts can be about this deep. You want to have somebody who can review that. The plans are probably likely to ask you to sign what they call business associates agreements. You've got to have somebody with a background in healthcare to review those business associates. Yes, what Cheryl said about the new rights. There's a whole process in Medicaid for complaints or grievances, and the way we'll come back to you and say, Marcella's one of your residents. She saw, she wasn't happy with the service here, et cetera. You've got to both understand that process, respond to that process, understand who responds to that process, and also train your staff and your team. If they're not used to that, that's going to be a real change and a shift for them, and it's going to be really important. You want to know what your salaries are going to be for 3 to 5 months. We estimate that from the time you start this process to the time you get your first checks from managed care, it's going to be probably in the 3 to 6 month range. So you're going to want to have to cover salaries from now until then. You're going to have caseloads and ramp ups. We don't know how quickly referrals are going to come to you. You may want to have 1 to 2 direct services staff to do this work at the start. Talk to your managed care plans in the conversations about how quickly referrals coming through. What do they say? You're reliant on them for referrals. Managed care is also asking you to make referrals to people, but they may come back to you, they may not. But you've got to factor in how long do you think it's going to ramp up for your caseloads. And then IT and vendor support. Again, these new data systems and software, it's not just purchasing the new system, but it's also making sure that you've got the customer service support to make sure you can make that work. So these are all part of your startup packages. And yep, new rights. Yeah, yes. Okay, so next slide, please. All right, I believe I shift to Allie here. Do I shift to Allie here? Or
Yep.
am I doing that too soon? Yep.
All right, thanks. Okay, so step 3, now we're going to talk about building out these cost estimates by month. So we're going to go into each of these phases in a little more detail, but this is kind of like the overall view. And this is just an estimate, depending on your agency, how much time you have to put into it, different roadblocks that could come in the way. This could be more or less, but this is kind of like an informal average of what we've seen working with other agencies, and help you kind of build appropriate expectations. So the first phase is going to be about 4 months from project conception to start an early implementation, looking at a first payment somewhere around the 6 to 9 month mark. And that is the first payment, not necessarily the first services you're providing, first person you're enrolling. And then expect a full implementation around months 13 to 18. So we'll go into each of these phases a little bit more now. So the initial months, you're like, you decide, we're going to do this, we're going to go for it. This is going to be great for our agency. You're going to want to develop a work plan with an initial budget, incorporate new revenue, just all those things that Marcella just talked about. And then think about revising your policies and procedures to align with any new financing mechanisms. And you want your fiscal staff trained on a new billing system if that is applicable to you. As Marcella mentioned, that may or may not be a need for you. You may be hiring out the billing. Either way, you're going to figure out how you're going to be doing that. And I also will say that there is a lot more that you're doing within these phases that I just pulled out the things related to like financial stuff, but there's a lot more within these on the different kind of lenses that you're looking at. So just keep that in mind as we talk about this. All right. The second phase we're calling early implementation. So that's approximately months 5 through 12. At this point, you really have a good sense of what type of revenue or amount of revenue that you're going to be bringing in, and that has been, communicated and agreed upon by supervisors, communicated to the frontline staff. The staff is going to start enrolling folks, documenting services, begin submitting the claims, and track lessons learned as claims are submitted, denied, and resubmitted. I think this is a big one that I've seen as agencies get going is there is definitely, if you are doing the billing yourself and it is new to you, and even if you're hiring out billing, there are going to be instances where your claim gets denied, and it takes time to go back and figure out why that claim was denied and how to fix it. And, the hope is that this is kind of more of a front end thing, that once you get going, those mistakes will happen less and less. You're probably never gonna always have clean claims all the time, but you're gonna get much better at it. You're gonna understand how to fix it. You're gonna develop relationships with the MCPs to help you with it, but you should expect some time on the front end here for your staff to be able to really dig into that and go back and look at those claims so you can ensure that you're getting paid. So because of that, and also lag times for enrolling folks, for just getting everything fully up to speed, you should expect some revenue, but not at full sustainability at this point. I tend to recommend to agencies to think about starting small and building from there, that you expect that you will have roadblocks and bumps along the way, and that having that expectation up front can be, it's just easier in the long run than trying to, from the beginning, like enroll every single person in your agency and expect full amount of reimbursement right away. It's just, if it happens, that's great. But if not, you want to be prepared for that so that you're not counting on revenue that is going to take longer to pull in than you expected.
I've been doing this for a long time, Allie. I have never seen that scenario.
Maybe.
I wish.
Yeah, you can always build up too, right? Like it, there's not really, there's nothing wrong with doing that. And that I think I've seen the most success for people that have lower expectations and work and build up. Then again, everybody trying to get everyone in and bill as much as possible right away. It's going to take some time. Okay, that was true. All right, we can move on to the next slide. So then we have full implementation. This is where you're going to start expecting that you're consistently billing, that you're having more claims successfully completed on the first time. That percentage is going up and up monthly. That there is a process that you've developed to reward staff meeting the billing targets and address challenges faced by staff not meeting targets. I think there's a lot in there, and I'm wondering if you, I'm guessing with some of the like service implementation stuff, we'll go into that later in terms of rewarding or addressing challenges by staff not meeting targets. Is that true, Cheryl?
We'll talk about it in our
Okay.
documentation and policies and procedures.
Yes, that's the one. Yes. So that you are being more successful in as accurately as you can, anticipating revenue and anticipating how much you're billing. The billing staff have solidified their processes and have strong relationships with the managed care plans to quickly address those billing issues. And so at this time, you're really rolling along.
As Ali said in the beginning, when you think about grants, you get the money, you do the work. Here, you're projecting revenue. You're looking at how much, what we call the pay in Medicaid, what we call is the payment mechanism. Are you being paid by the hour? Are you being paid by the day? Are you being paid by the month? How often do you expect to see people, and therefore you can draw down a payment? What's the rate of that payment? And then that's how you build out a basic revenue projection. We think in a month, these direct services staff seeing this many people doing this much work will be able to bring down this sort of revenue. It's really a shift in order to be managing based on revenue projections. And so we want people to begin to understand how that works. We want you to anticipate what the payments are and be able to pull that into your process. Quantity, how many of them you're pulling down, and then variability, what changes over time. And we'll give you a lot of the examples of when things just don't quite go right, because everything, there's a lot of variability when there's this many people involved. Yeah. Cheryl's got a share out from the group here on here that I think is really good. If the folks who are holding contracts now, what are the minimum requirements? Generally speaking, Medicaid will say, okay, we're going to pay you per member per month. And in that month, you must do X. You must see a person 3 times, once in person. You must fill in the blank. And when we come back to do an audit to say, okay, we paid you for X, show us the evidence of that, that you're going to be able to meet those documentation requirements. So as you estimate revenue, think about who you're currently serving. You want to think, are they enrolled in Medi-Cal or not? You want to think, who are their health plans? Because those are the health plans that you want to pursue contracts with, the people that you're currently serving. You also want to think about what's the consistency of their Medi-Cal coverage. I just want to shout out, and CSH and National Healthcare for the Homeless will have a webinar on this shortly, that we are about to enter what's called the Medicaid unwinding period. States have not been allowed to what's called redetermine, meaning assess people to see should they remain Medicaid enrolled or Medi-Cal enrolled, excuse me. And so that process is about to start. The state should not have been disenrolling anyone from Medi-Cal for any reason since March of 2020, i.e. the start of COVID. That's going to start shifting. So you're going to have to watch the Medicaid unwinding and how consistently your folks are covered, and do everything you can to support them to make sure that coverage is what we call continuous, meaning there's no gap in coverage. So you've got to think about demographics. Who are you currently serving? Who are you making referrals to for community supports? Do you know who's Medi-Cal enrolled among who you're serving? Do you know what their health plans are? Can you make those referrals? We're hearing the health plans are expecting often agencies like yourselves in order to do those referrals. Now, you're expecting a referral to come back to the health plan, but if you're currently serving someone and you think they're eligible for community supports, and we'll talk about who's eligible and how that differs plan by plan, you're going to be what are putting in those referrals in. You also want to know, are they providing services? What data do you better need to predict eligibility? Generally speaking, states communicate by mail. So it's going to be around Medicaid. There's some work around trying to get to do more phone, to more text, but often it's really mail and or they're looking for email. How much do your residents, open their mail? Do they understand what it says? Do they understand what the letter is telling them to say, you have to do A, B, and C to keep your Medi-Cal coverage on? So you're really going to be looking closely at that over the next couple of months, not just from a doing community sports perspective, but just to make sure they can access the healthcare services they need. MCPs have data on healthcare utilization. It's not equitable. It's who gets into a system and who bills for a system. And there's a lot of structural racism baked into our system, so be aware for that. But we expect that the MCPs will be doing their own internal analysis and saying, these are the people who, gosh, they seem to be costing a lot for their healthcare and we don't understand why. And oh, wait, they don't have a stable address. They click the homeless box, etc. They may be reaching out to them and saying, hey, you could be eligible for community supports. If they get that information, how do you help them sign up? How do you help them get assigned to your agency? Homeless services providers can help do all this work. You can refer the clients to community supports. You can particularly work to make sure that BIPOC individuals have equitable access. Gosh, I will see homeless people, people experiencing homelessness, excuse me, I should use person first language. They go to an ED and some group of people get past the security guard and some group of people don't. And I bet if everybody ever did a study on that, it would be very, very inequitable. So healthcare plans are going to go back to who's expensive to them, but if people can't even get access to the services and the coverage, they're not going to come up as expensive to the health plans. It's going to be really important from an equity frame to make sure that the health issues all of the people you serve are being addressed, and to make sure that the health plans are doing this in an equitable manner. They're required by the state to do this in an equitable manner, but people haven't really defined what that means. So your role here as an advocate for the folks you serve is going to be really, really important. You need to be sure that their Medicaid enrollment is active. We make a distinction between a person who's Medicaid eligible, meaning they have all the characteristics of someone who should be a Medi-Cal enrollee, and that they're enrolled, meaning the state systems, the managed care systems say, yes, Marcella's benefits are turned on. If she gets healthcare services today, we, her MCP, are going to pay for that. You're going to need to look at your caseloads and think about intensity of services. How often do people need to be seen? Some people need to be seen daily. Some people can be weekly. Some people can be more than that. There's variation in the acuity. That variation changes over time. That's going to be really important for revenue projection. Particularly if you're not with a MCP that's doing a PM or per member per month. If it's doing per diems, if it's doing hourly, you're billing for that amount of time. You need to see, gosh, here's how much time this group of people needs, that group of people needs. This is how much we'll be documenting for our services. This is a revenue. This is what revenue we think we can be generating. Does that revenue cover our costs? You want to predict frequency, do your best to predict frequency of visits. You want a range of that. Some people are higher acuity today, some people will be higher acuity tomorrow, but you want to predict that over time using your current data, and you want to use that data to predict what revenue you're able to bring down. You also want to think about the number of people you're served by their current service type, what you call that, what the funding source is. Your financial management system is going to need to pull that out and pull that apart. Can these sources be braided to complement and supplement the services? Can you increase salaries? Can you lower caseloads with new funding without supplanting? What they're asking to see is not that, oh, now we're billing Medicaid, so we're going to, take this other piece of revenue and we're going to put it back into our agency budget. If they want to make sure that that's still in the same program, but they don't want to. So that's a really important piece that you're going to have to think through. And we're working on guidance and coverage around the whole challenge of supplementing versus supplanting. So yes, so next slide, please. So both fee for service and PM considerations, what kind of referrals will you receive? Will you have new clients, people you're already working with? You know how, you know them, you know what their needs are. You know how often they need to be seen, you know what assistance they need versus new clients. A lot of times people need a much more intensive service in the beginning. Certainly when they move into housing, they need a very high level of touch there often. And how does that change over time? Do people need high touch for 2 months, 3 months, 6 months? Does it come down? You're going to need to know all of this as you, or have some guesstimates of this, I should say, as you're beginning to generate revenue. How many new referrals are coming in, how often they come in, how do you make sure staff have the time to spend with the new people they need, what revenue does that bring in, but also you don't want to overwhelm staff, you don't want to burn in staff. How often are they being seen, and what revenue generation does that being seen give them? Outreach time, how much time does it take to engage people? How much time does it take to move in? Also know that if you are on a per diem rate or an hourly rate, if you do not make contact with a person, you generally cannot bill. So you may have gone out, you may have spent time looking for them, but if you don't make face-to-face contact, check with your MCP for the rules on this, but it usually means you can't bill. Outreach is usually not covered in this way. So you've got to build that into your costs as well as your estimates there. Ask the MCP though, is there any way when we're doing this, when we're trying to bring, is there any way to get those costs covered? Usually there's not a face-to-face contact, at least in the beginning. That may not be made. And if you're on a PM, then what you're thinking about is, okay, I'm required to, for example, see a person 3 times a month. I can go out a couple of times and find them, but if I'm going to bill for that month, I need to be able to find them at least those 3 times that are required. You want your caseloads to have, and your caseload reports and documentation to have your number of authorized members. Authorized means the healthcare plan says, yes, Marcella qualifies for the services. She is enrolled. She is our health plan member, and we are going to pay you for their services if you report to us that you've delivered them. You want to know, so the number of authorized members served during a month, that'll give you some revenue projections you can do, and the rate of reauthorizations. Health plans we're seeing, I think I'm mainly seeing a year. Cheryl, are you seeing 6 months? You're seeing 6 months too for some plans?
I'm seeing a year for authorization typically for the first year. And then some plans are requiring that every 6 months after that, people need to be reauthorized. Others are saying 12 months, 12 months, 12 months.
12 months. Okay, so that's good. I mainly was seeing 12 months to start, and then which same things as what you said. So what I will say is that you have to build into your administrative costs the authorization process. When an authorization lapses, it does not mean the person still no longer needs services. It does not mean that the person is no longer eligible for services. It means you as a provider have to make the case again about why the person needs the services, why the person meets what's commonly called an MCP speak, medical necessity criteria. So often we see, I would often work with homeless providers who were like, oh, so-and-so doesn't get the services anymore. And I was working for a managed care plan at the time, and I'd say, nobody asked us for more services. We can't pay for services until somebody asks us for services. So you've got to build into your costs there. What are the staff that are going to manage your authorizations and your reauthorizations? We also recommend that, generally speaking, on a maybe not daily, but weekly basis, you check to make sure people's enrollment is in. Once we get into that redetermination period, people fall on and off coverage all the time, unfortunately, in the Medicaid world. We even have a term for it. It's called churn. And you want to minimize churn. You want to make sure that people have continuous coverage. So you've got to be checking in to make sure that they're still that. That's an administrative task, and that means it's a staff cost. So build that in as we're talking about costs. That would be a sustaining cost. That's something you're going to be doing, not just at the start of your program, but for your whole program. So these are all some pieces of detail. So what impacts your revenue projections? What things do you have to build in? Ali, I think you said this earlier, expect everything to go wrong and build that into your revenue projections. So you don't know how often referrals you're going to get. I think this is also to Ali's point about start slow, have a staff person or 2. Let's see what the rate of referrals comes in. You are able to have with the managed care plans and say, okay, we're going to start with 2 direct services staff, and they have a 15-person case, and they have a 15-person caseload. And so we will take as many as 30 referrals over a 3-month period. It can only be in this time period. You can set that with the managed care plans. That's your capacity. They have to follow that with you. They'll make referrals and fill, but then they have to take your no. That's built into some of these contracts, but you don't know how fast that's going to happen. So be ready for slow or inconsistent referrals. Member authorizations, this is why you want to stay on top of. You want to have something that says, oh, it's about a month or so from when, so-and-so's authorization is going to lapse. We need to do the due diligence in order to get the information so that we're going back to the MCP and saying, we need an additional authorization past the current date. So health plans will give you an authorization date from January 1st until June 30th. Marcella is authorized for services. That means somewhere around June 1st, you're starting to do an assessment again and say, does she still need the services? And you're starting to call the plan and say, when are we doing the reauthorization? When are we doing what the health plan would call utilization management? You don't want the member authorizations to lapse. You want it to be absolutely continuous so that when you serve me on July 1st, you're under a new authorization and you're still getting paid for that service. Medi-Cal enrollment lapses, this is what we talked about. This is going to be really important in the redetermination, as the redetermination process steps up again with the unwinding. You need to make sure that people have continuous coverage. The state will be communicating with people. The state will be putting out materials saying, here's how you help people keep their coverage. That's really important, whether you're billing for them or just making sure that they can access the doctors and medications and all the things that help them stay stable in their lives. You don't want that coverage to lapse for them. Claims get denied. That is just an absolute truth. Claims get denied. Sometimes claims get denied for things you can't change and you cannot resubmit the claim. So for example, if my authorization lapses, nobody, asked for a new authorization for July 1st and you serve me on July 1st and you try to bill for it and I'm not enrolled on July 1st, then you're going to get a denied claim. That's the kind of claim there's nothing you can do about. But there's a lot of claims that get denied because, as we like to say, the I's don't get dotted, the T's don't get crossed. Gosh, the legal name of your agency has to go on every claim. And if we say Main Street versus Main Road, they're going to kick that back. If you're enrolled as a provider at 123 South Main Street and your claim says 123 Main Road and everything else matches, they're going to deny that claim. But you can fix it. This is again a staff cost. Your billing staff should be going through denied claims. You get reports back from MCPs in the claim world. It'll be interesting to see how they do it if you're submitting invoices and you say, oh, that's a mistake. I can fix it. I'm now going to put on Main Street. I will resubmit. I should be able to get that fixed. Rate changes over time. The MCPs have a contract with you. Someone's going to have to read that contract carefully, but rates can change over time. And you want to see if a rate changes, that's going to impact your cost estimates. And then delayed reimbursement. As we said, the state requires 90% of claims, I think you said, Cheryl, to be paid within 30 days, but that's a process. Remember, that is for a clean claim. So if I submitted that claim that said Main Road instead of Main State, they don't have to pay me in 30 days. They've denied that claim. I have to fix that claim. I have to resubmit, and then the 30-day clock window starts. So you've got to build all of this understanding of how the system works into your financial projections. So next slide, please. Ali's point, and everybody read the chat for Ali's point about folks not signing things, folks not, how difficult it is to document disability, things of that nature, all true. We talk in some of the material in an upcoming session, I think, about the communications plan, not just with your staff who are doing this, but with your residents and the people you serve, how this is a shift. Talk to them about what's going to happen. They're going to have more forms to sign. They're going to have more times when people ask them a bunch of questions that they don't understand why. Help them know this is helping you build your program and save and sustain your program. So a couple of other things, impacts on revenue projections that we want to talk about is if you're fee for service, if you're on 15-minute increments, if you're on hourly or per diem, you're going to have to be able to predict how much does that happen. This is not as important if you're in a per member per month situation, a payment mechanism, etc. But if you're billing for a discrete amount of time, you need to understand, gosh, how much time do my staff spend in billable, not valuable, billable activities that we can actually bill for. Most commonly, that is face-to-face interactions. Travel is not billable, that's a federal rule, etc. But you've got to build that into your revenue projections. The number of clients that your agency is referring to managed care for community supports, how many as people are you serving at any given time, how much revenue do you expect to generate on each of them, what it takes you to make sure their Medi-Cal enrollment is renewed on time. You may have times when people lose their coverage for short periods of time, hopefully, and you're not going to get paid for that time. So again, that's why it's important to make sure that people's coverage stay on, that staff are focused on this, why it's important that staff also are focused on the authorizations that don't lapse, because you don't want to lose any, possible revenue there. The accuracy of claims that are submitted on first attempt, as Ali said when she talked about that, early implementation stage, folks just get it wrong. There's a lot. We'll take you through the forms for some of the plans, et cetera, but there's just a lot there. People get it wrong. That's standard. You get a chance to fix it, but it does mean that that revenue coming into your agency is delayed, and you've got to be able to build that time in. Reauthorization numbers, if that aligns with expectations. We haven't seen, nobody's been doing this service, I think, long enough to know how MCPs will work with reauthorization. So that's important. As Cheryl said, you're going to get a year, but what happens at the end of that year? How does the plan communicate with you to say, this is what we need to do a reauthorization? This is what our medical necessity criteria is for continued tenancy sustaining services. You will also have people shift. You will have people that you get, maybe you're unsheltered, they're going to get tenancy navigation and transition services, and they're going to get that for a certain period of time, maybe a year. But then the plan may say, okay, once somebody's been in housing for X amount of time, and that now we're going to shift them to tenancy sustaining services, how they do that. I haven't seen too much on that yet. We're digging into that, but that is a common practice. You're going to want to be in regular conversation with your MCPs. You're going to want to know who your provider relations rep is. That's your window into the MCPs. They're going to be able to answer these questions for you. So make sure that the reauthorization process aligns with your expectations. And then again, resubmit corrected claims. If you made a typo here, if you put the wrong HCPCS code in, if you didn't put the right service code in, et cetera, and the claim didn't go through, and you can change that, fix that, but fix that, resubmit, get paid. But you're going to have, administrative staff, billing staff who look at those claims, who fix those things, and who resubmit for you. All of this has to be built into revenue projections because it's going to impact what comes back to you. Next slide. So estimating cost load sizes. CSH feels very strongly to deliver quality services. You need to have the evidence-based caseload sizes of a very low number. We've seen caseloads as low as 10, as high as maybe 20, 25. Higher than that, you're really not commonly delivering a quality service. You're just not able to. It's too much. Having been a case manager, it's just not enough time to spend with what the people need. You're going to have to make some projections about how big are those caseloads from your revenue. You want to know who you're serving, what their level of needs are, how many people are new to your service, because people need a much more intensive service in the beginning. I was an ACT case manager, like Cheryl was, and we wouldn't take more than 5 people on our team a month. That's the industry standard for ACT, because we knew we couldn't spend the amount of time with them that they needed in that beginning time. So who are you serving? What are their needs? What's the best practice service model that's matched to their needs? For chronically homeless folks with serious mental illness and SUD, it's commonly assertive community treatment. You may have a lesser acuity population that gets a case management model or a team model. Are individuals new to supportive housing, that critical time when people move into housing, really, really important. It's a huge change from life on the streets to moving into housing. So they're going to need a lot of hands-on support at that time. Are your case managers new? They're going to need more support. They're going to need more hands-on support from supervisors. They're going to need more team members, et cetera. And are you doing tenant-based versus scattered site? Remember, travel is not billable. That's a federal rule. If everybody's in the same building, you may be able to have a higher caseload. But if everybody's scattered across Los Angeles, then you're going to have a smaller caseload, and you're going to need to build in travel time, knowing that travel time is not billable. There is, Cheryl put a link in the chat for what is called non-binding ILOS pricing guidance. What that translates into is what the state handed to the MCPs and said, we think on average, this is what you should pay for this based on their own internal analysis. That's great, but you guys are living this every day, which is why we're taking you through all these ideas about revenue projections, et cetera, why we're going to spend so much time on the services budget tool next session. We want you to understand, as we said, your total cost of care. We want you to know how much time you're spending with people, what your revenue projections are going to be, and therefore, in order to cover your total cost of care and have a fiscally sustainable program, this is the rate that you need from the MCPs. That may fit with a non-binding LAOS price guidance, that may not. So this is all part of what you negotiate price context. But as Cheryl said, it's really important to know this is what the ILS pricing guides, especially if they're trying to give you a lower number than that. But they can say, well, we're not required that, it's non-binding, and we can say yes, but here's what we've done with our services budget tool, here's our analysis, here's what it costs to deliver a quality service, so this is what we need in order to enter into a contract. So yes, staffing plans are new. So we have been talking about the services budget tool, and that's a lot of what's happening in our Money Matters 201. I believe at this point, I'm handing it over to you, Cheryl. Am I correct?
Jump in real quick with something?
Oh, absolutely, yeah.
I just want to say, like, I feel like sometimes when we do these, it can get really overwhelming and maybe kind of discouraging feeling because of all the things that you have to take into account, and it's so different, and there's so many places where you get like can get held up. So I don't want people to take away that message and to think about kind of also some of the upsides to this funding model. So I mean, for one thing, I think that having the Medicaid funding in the long term can be more predictable for agencies, because they know once you get going, you can do a better job of predicting your revenue, and you can kind of just keep going and know into the future that this money is going to be coming in as long as you keep providing these services in this way. And you're not subject to the grant program issues of having to reapply every certain amount of time. Maybe your grant program gets zeroed out in the next, state budget year, or the private funder that you're really reliant on decides, like, now early childhood literacy is more important than homelessness, so we're not funding you anymore. You don't have to worry about that stuff so much. The other huge benefit is that you can increase what you're doing over time, because you work with more people and you get more money. Whereas a lot of like the HUD grants, I know that a lot of agencies that I work with, like their HUD grant, they have a little bit of a cost of living adjustment, but they really don't go up over the years, and the costs have gone up. And so what do, right? You're stuck with only serving a certain amount of people, even though you have hundreds of people on your waiting list. You only have a certain amount of money, and you never can take more. In this instance, it's not automatic, and it might be slower. You can build up more capacity to serve more people, as many as you want and can do. And the rates can increase too. Like Marcella was getting at, you have negotiating power with the managed care programs. And when they see the value of your services, there are many who want to pay adequately for that. And as they see the value go up and they see what you're doing, you might get a rate increase over time. So I think I just want to, I wish I had put in, I think sometimes I have here's why you want to do this, and maybe put that in the beginning so people don't get a little overwhelmed. It is a lot. It's a lot to think about. And I think you should temper your expectations. This isn't a silver bullet. It's not going to solve all your funding issues, but it is, there's also good reasons to take all this on, even if it might be a little overwhelming at first. So I just wanted to put that in there.
No, no, no. I really appreciate you doing that, Ally. I get into the details and weeds and all the challenges here. I also want to reply to Hector's comment, talking about travel and not being billable. Let me clarify. When you are billing under 15-minute increments or an hour, you cannot say, oh, I spent this hour traveling from client A to client B, we're going to bill. But when you're on a per diem rate or you're on a per member per month rate and you've met the expectations of the plan for how much services you've delivered in order to pull down that per diem or that per member per month rate, then the issue that I'm talking about in travel is irrelevant. So, and what Cheryl said in there, okay, so it's a bundled rate. That's what we mean by the per diems or the PMPMs. Then yes, of course, especially in a scattered site program, you're going to be traveling, and you're going to be paying the staff for the time that they travel. So yes, I made a mistake. I am not done yet. Let me keep going, but we will get into much more details about this as we go to the Money Matters 201 session next month. So next slide, please. So this is the document that we had a link to before, the non-binding, which means this is the state saying to the MCPs, here's what we think you should be paying for community supports. ILOS is a managed care term. I think mainly what you're going to be hearing now is community supports, but know that community supports fall under the heading at DHCS of in lieu of services, or ILOS. So take a look at this. This is a really, if there's one DHCS document you open up and look and, hang on your wall somewhere in your office, this is the one you want to look at, because it'll give you the codes and the pricing, costs, etc. for all of these. Know that there are 14 different community services. You're mainly concerned about the services that you're going to offer. The services that we're covering in this training are only 3 of the 14 community supports. That is housing, housing navigation and transition services, housing deposits, and housing tenancy and sustaining services. So next slide, please. So again, this is kind of another way to tell you about what we heard from Ally in the beginning when we talked about grants. In the grants rules administratively, you write a proposal, you get paid, you do the direct services, and then you write the report. And you just go back and around in the grant world like this. In the Medicaid world administratively, there's a lot more to do that. And you'll see there's a lot of things you do before you get paid in the beginning. One, you have to have a contract or enroll as a provider. For traditional Medicaid service, you have to enroll as a Medi-Cal provider. Now, in the case of community supports and in lieu of services, what the state guidance says is that plans are not allowed to require you to become a Medi-Cal provider. But I will say, as I'm digging more into the plans, they're doing everything but, because that's just how they operate. So it's going to be really important to say that you're not requiring that, etc., but know that it happens, know that it takes time. Almost every plan's documentation that I've looked at requires what's called the National Provider Identifier, or an NPI number. And we'll take you through some of that and how you get your NPI and doing all of that. So you think about what it makes sense for your agency to do from a provider enrollment perspective. You get a contract with the MCP, you negotiate a rate with the MCP. A lot of MCPs have this letter of interest form that you have to fill out. We'll talk about that in the sessions in March. You have to make sure that your people are enrolled. Maybe you haven't tracked that before, whether your folks the folks who you're serving have healthcare coverage. But that's going to be really important, and you're going to have to stay on top of that. You're going to have to ask the MCP for authorization for services. MCPs will only pay for a certain period of time for people who are their members. But as Ali said, you've got the potential for growth here. You've got the potential to serve more of the people that are coming to you that you don't have the resources to serve right now because the grants aren't big enough. This grows as the need grows. That's why it's important that Medicaid is an entitlement program. You serve the authorized people, you document the services that you did during the authorization period, you make sure the authorization period stays current, you make sure the Medi-Cal enrollment stays current, and then you submit claims on a weekly basis, monthly basis, we say, and then you get paid within that 60 to 90% of the time. This is what happens when we know that a number of you are in communities where maybe the COC or some other administrative entity is going to be building out that infrastructure in order to bill. And so this is the process that you will be a part of, that orange piece. If somebody else is doing these other pieces, you may just be doing the orange piece. And then they will come back to you with a payment afterwards. Cheryl, do you want to talk any more about that or highlight? Yeah.
Yeah, there are a number of you that are in locations where there are existing larger entities, whether it be in San Diego, there's a 211 network. In Los Angeles, it's the Department of Health Services intensive case management program that hold contracts with managed care plans and then subcontract out to homeless service providers. So for those of you that are operating in those counties, the orange pieces here, serve authorized people and document all services, that's the only portion within your subcontracts that your agency will be responsible for. But you are, as a subcontractor, indirectly receiving funds from managed care plans that are then going through the Department of Health Services to your agency. So the Department of Health Services in Los Angeles, for example, is right now doing all of those other things. They are making sure that people are enrolled. They are ensuring that people are authorized. They are submitting claims. They're working on HIPAA compliance and monitoring internally the quality of documentation. That funding to you doesn't change, even though they may be pulling and braiding different sources in the background. You will still be being paid for what you are contracted to provide, that are your housing and homeless services. But I just want to point that out because there are a number of folks that may have heard a lot about these opportunities for Cali and community supports, and then sort of like the pinprick in the balloon of, wait, someone else is where we can't, it doesn't make sense for us to be a provider because the county holds the contract. And I just want to paint the broader picture that in many ways, for those of you that are operating in those counties, it is taking that administrative burden away from you, but it's still going to be really important for you to know and articulate your total cost of care. So regardless of if you are negotiating rates and directly contracting with a managed care plan, or if someone is negotiating on your behalf, oftentimes those larger entities, they have a lot more sway and they have a lot more negotiating power. If they're saying, managed care plan, we're bringing 72 providers to you, they have more power to negotiate a better rate. But it's really important that whoever you're contracted with understands what your total cost of care really is, so that when there is time for renegotiation, you're able to share with those entities what it really would cover your costs and sustain your staff and help you to ensure those evidence-based outcomes. So there's one more slide that just shows that difference. So you may opt to go for both of these buckets. You may want to hold some direct contracts with managed care plans. And if you're in a region where there's a larger county entity also contracting, then it may be a small program. You may have slower referrals. It may just be a few staff that are working on this, but it may be worth your agency's time to build that capacity internally, because we know that Medi-Cal and the healthcare system is not going away in terms of their interest in seeing people housed and in funding housing related services. It's exploding across the country. It's going to be something that in your long-term interest of your agency, you're going to want to understand and know how to do this. So it could make sense to have a small contract and also be subcontracted to a larger entity. And I see in the chat, Janai, yes, thanks. And if you want to come off mute and share, this is just an example of that you may be negotiating with someone at a managed care plan and spitting back to them guidance that has already been published by the Department of Healthcare Services, and letting them know what is allowable.
Thank you, Cheryl. I appreciate your help. Your technical assistance was invaluable. Yes, we had to, after talking with you, we had to look at the rules, and exactly that. We had to spit it back at them in language that they could understand. That when we went to the enrollment portal, of the, from Medi-Cal providers, there was no pathway. And I didn't understand what a pathway was, but there was no way to enroll a community supports housing provider. There's no code, no nothing. And so once I figured that out, once you helped me figure that out, then I had to kind of cut and paste and then explain that to them. And then they understood. I was able to get a national, what is that national code?
Provider ID, the
yes.
NPI number.
National Provider Identifier, NPI.
Yes, but even that didn't help. It just identified me in their system as a provider, but it didn't even come up in, when they plugged it in, it did not come up with our MCP at all. But I did went ahead and enrolled in the National Provider Identifier. So now we're up to just reading our contract and getting ready to look it over and sign it. So we're glad for it. Thank you.
That's awesome to hear. Yep. What the language that Janae used, it's page 13 at the top of the document that I put in the Community Supports Policy Guide about how there is no pathway to prior enrollment for housing and homeless services providers. You're not an outpatient clinic, you're not a home health aide, you're not a hospital agency, you're not a home health agency, you're not a hospital, you're not any of those things. So this may be something that you want to, so if an MCP plan tries to tell you, like they did with Janai, you'd be like, oh, my understanding is this. With DHCS guidance, that can be very powerful.
Yes, and I do want to share, so this academy goes through May. There are some opportunities. We're not meeting again until March 8th, but February 27th, the second round of grant applications, February 27th, you'll be able to submit applications to get free technical assistance paid for by the State Department of Healthcare Services. So I highly encourage you to check out the website now. Read what types of things they can provide technical assistance, read through the vendors. If you want our thoughts on if there are any vendors that we might say, hey, this one might be a good fit for you, you will have the opportunity to either select a vendor or to be matched to a vendor. But those applications open up on February 27th, so a week before our meeting on March 8th. Also, the grant applications for round 2 of the cited, which is capacity and infrastructure transition, expansion, and development. These are grants that are specifically for providers like you. Whether you have contracts right now, but are still in that startup phase and trying to figure out, when we bring billing in-house, how much is it going to cost us? And we probably need to add another compliance person or staff. Do we need to have a consultant to help us write policies and procedures or revise our workflow? This is grant funding that can help cover any of those costs. It can cover startup for hiring staff. It can cover staff time for working on all of this. You don't have to have a contract yet. You can say that you are interested in and in conversation with managed care plans or have submitted a letter of interest, and that's enough to get your grant application in. It takes some time. So for those of you that, there are a few of you on here that did receive funding from the round 1A grant applications. So if you want to share any insight in the chat of how many months it took from when you submitted your application to receiving the grant, feel free to share that with the team. But these are 2 opportunities I just want to highlight for everyone, that especially finance staff, as you're thinking about startup costs, it can feel really overwhelming. And there was $1.85 billion put into this path funding that's, overseeing several different buckets of things, but it is significant funding. And so it's something that we want to be sure that homeless and housing service providers can tap into. Also, on our last training, we received a question about Spanish language resources for training. So when we were joined by Jolene and Ariana Saunders, they were talking about trauma-informed care, harm reduction, motivational interviewing, these evidence-based practice approaches. And someone had asked, are there trainings available in Spanish? So CSH is partnering with Homebridge, which is a provider that actually puts on trainings for home healthcare workers that are providing in-home supportive services across the state. But some of those trainings absolutely align with supportive housing best practices like harm reduction, trauma-informed care. There's going to be one on supportive housing 101, and these trainings are available in 6 languages, including Spanish. So I want to make sure that you all have that link. The ones that will be created by CSH are not yet on the website, but save it, and I will let you know as soon as they are. And please keep the questions coming about resources. And we want to be sure that we can collect and share trainings that are free for staff. So as we learn about HIPAA trainings that are happening and compliance trainings and other TA efforts around the state, we'll keep pushing those to you so that you're able to access them. Okay. Thanks, Janai, for sharing in the chat that it took about 3 months from writing the path cited grant to getting notified. Okay, that's very helpful. The other resource I want to spotlight is In Their Own Words, Black Californians on Racism and Healthcare. So this is the first part of a multi-part study that was conducted in 2022 and 2020, throughout 2022, and the end part of 2021. This is going to be really important as you articulate to managed care plans how you, who you serve, and how referrals from you will help them to achieve ensuring equity in authorizations and in persons served. It's going to be really important that we're articulating that people who are showing up in the healthcare system are going to be underrepresented if they're Black, Indigenous, or people of color. And there are reasons for that, and systemic racism is one of them. And so this is a nice overview with quotes and a lot of people's voices in it from across the state. And so I just wanted to share it with all of you. I think as much as we can, we have a lot to learn from managed care plans in terms of how to provide services, document them in a way that will get us paid and grow our programs, but there's also a lot that we can share with them. Okay, so we're at the tail end of our time together today. So we always have a reach for next steps. So I have put for the reading, the In Their Own Words report. And then if you have not yet checked out the Medi-Cal Academy folder, we upload each session, we upload the PDF slides. So those PDFs then have all of the links active. So everything that we've thrown into the chat, you can link to it in those PDF slides. We also will be putting the recordings there. We are including all of the tools and templates that we have shared. And so the business plan planning templates are there, and those tools, the services budget tool is there. So want to make sure that you have access to and are exploring those. And then again, encouraging you to explore the PATH funding and the TA vendor marketplace. I think I've said it enough now, but our 201 session on Money Matters is on March 8th. I want to ask that you have ready questions that came up for you related to using the services budget tool. So take these next 3 weeks to start inputting in current costs. If you have questions, you can reach out to us at medicalacademy@csh.org. And then we will take time to walk you through the tool, to answer questions about how do you gauge estimating revenue when we have no clue and have never done this? How do we know what % of people are going to be new? Well, there are averages that we're seeing from, within California and across the country. So we'll be able to talk through what some safe guesstimates might be for different costs, startup and ongoing. So please plan to have questions ready. Anything related to projecting revenue, stuff you're currently working on, we're going to have time for breakouts and want to be sure that you feel like you're coming with questions that you want to get answered. And thank you all so much for joining us today.